Hello and welcome to PBS Updates, a new short series from the Oncology podcast where we break down the latest changes to Australia's pharmaceutical benefits scheme and what they mean for oncology practice. This is Rachael Babin from the Oncology Network, and I'm joined by Professor Craig Underhill. In this series, we take a quick look at the recent oncology and haematology updates, what's changed, which patients may benefit, and what clinicians should know. For more detail and ongoing coverage of cancer medicines, you can also visit oncologynetwork.com.au. So, if you want a fast, practical overview of the latest PBS developments, you're in the right place. Let's get into it.
G'day. Welcome to PBS Update Episode 2. Rachael, I heard we've actually had some good feedback from the first episode, which is amazing.
Yes, nice to be back with you.
It is nice to be here with you and not those people from the other side of the ditch telling us about how poor they are in New Zealand and how they can't have these drugs. So it's actually nice to have a segment just on the PBS changes in Australia.
We're very blessed, aren't we, with the PBS system that we have in Australia. And that's a very nice reminder before we get into the details. So thank you. And yes, we've had some great feedback. So I'm glad the listeners have been enjoying this new series. So this was episode 2, and we promise we will try keep them short like the first episode, because we think that probably helps everybody to listen whilst they're on the go.
Well, I was amazed that it's only a month later and we've actually got 6 new listings to talk about. It just shows how far the whole field's progressing. It's great to see these new listings with innovative molecules.
I agree. You know, when we were originally planning this series, we thought, maybe one every 2 months. But there's been so much, and I think it is a reflection on how things are changing.
And Rachael, I think you were going to mention the industry spotlight.
Just a quick reminder. So we will include all the papers and press releases and any documentation related to the episode in the show notes. But the industry spotlight section on our website has all of our cancer drug news, covering the PBS, but also what's happening with FDA updates and updates in general. So that's your go-to spot for information in this space. There's plenty to talk about, so let's get stuck into it.
Yeah, well, the first one I want to talk about is a drug called Repotrectinib. So this is an oral tyrosine kinase inhibitor, and it's been approved in Australia to treat ROS1-positive non-small cell lung cancer, and it also has activities in MTRK-positive tumours. It is a next-generation compact macrocyclic TKI that inhibits the ROS1 and TRK family proteins, and it's also notable in preclinical activity and subsequently clinical activity to be efficacious in tumours that have some resistance to first-line TKIs like crizotinib or entrectinib. So this listing was based on the results of the Trident-1 study. Big shout out to Melbourne's own Den Solomon, who is one of the authors in this New England paper from January 2024. So Trident-1 study was done, was a phase 1 and 2 study done in 2 cohorts. One was patients who had not previously received a ROS1 TKI, and another cohort in patients who had previously received TKI. So in total, there was 520 patients enrolled in this study. It took 5 years to enroll that many. This is a kind of 1% to 2% of lung cancer, these ROS1-positive non-small cell lung cancers. And the top line results were a response rate of approximately 80% in patients who had not previously received ROS1 TKI, duration of response 34 months, progression-free survival 35 months. And in those who had previously received one ROS1 TKI and not received chemotherapy, the response rate was 38%, median duration of response 14.8 months, progression-free survival 9 months. There were 17 patients with a specific ROS1-G2032R mutation, which confers resistance to the first-line drugs. 10 of 17 or 59% responded. So of the 426 patients who received the phase 2 dose in the study, the most common side effect in about 60% was dizziness. Although that was quite a high rate, the rate of grade 3 toxicity was low, but the adverse event of particular interest is pneumonitis, and so patients need to be monitored for that. And while other side effects can be managed with a pause and then restarting at a lower dose, pneumonitis was a reason to take people off study. So an active drug in this population, and the conclusions were that this was another treatment option for these patients with a rare cancer.
And it is quite a small group of people we're talking about.
Yeah, I'm just trying to do the maths in my head, Rachel. So 1 or 2% of lung cancer, but there's tens of thousands of patients a year with lung cancer. So I'm not sure overall what the expectation was from the PBS or PBS for the number of people that would benefit per year. And now this is just one of the treatment options for them.
Well, it's great. And yes, congratulations to Ben Solomon. Always nice when we see Aussie names on these big international studies.
And it really highlights the great work that TOGA and other groups have done for all patients diagnosed with lung cancer, be it early or late, should again receive the next generation sequencing testing to look for rare mutations. And then if a target's identified, if a drug's available, then that becomes a treatment option for the patient, either up front or down the track.
It seems to be the theme of most of the conversations that I'm having at the moment. I think the case for the next generation sequencing for all patients, ideally, is being made, and the nature of oncology practice is shifting so remarkably. I think it's a fascinating time.
Yes, and Rachel, I'm going to talk about a paper in the next episode of the OJC.
Ooh, teaser.
About a recent paper by Omiko talking about the benefit of the testing. So we'll get to that.
Oh, well, I'm looking forward to that. And in the meantime, I think we've seen some changes with Durvalumab.
We have seen some changes with Durvalumab. So it's again got another listing. This is time for patients with muscle-invasive bladder cancer on the back of the Niagara regimen, which is giving 4 doses of Durvalumab as a neoadjuvant treatment, followed by doses 8 cycles afterwards. The neoadjuvant Durvalumab's combined with neoadjuvant gemcitabine and cisplatin in the study, but then the 8 cycles post-op is Durvalumab on its own. So this was first presented at ESMO 2024. We'll put a link to the paper. Event-free survival has showed a hazard ratio of 0.68. So at 24 months, 67% of patients are alive without relapse and 59.8 in the comparator arm. Overall survival at 24 months, 82% versus 75, hazard ratio 0.75. So in terms of, neoadjuvant adjuvant approach, this is a 7% difference in survival at 24 months. Most patients would accept the extra toxicity, which is, as we all know now with the immunotherapy drugs, can be not insubstantial and life-changing and needs to be managed by a multidisciplinary team. But on the basis of that study, this drug is now available for this group of patients.
Excellent. Okay. And new indications for Pembro as well, I believe.
Yeah. So the Pembro people, of course, have been a bit disappointed because they haven't got a tumor agnostic listing like Nivolumab and Ipi does, but I understand following the listing of these drugs that there's still ongoing discussion about some kind of listing. But 3 new listings for Pembro, overall about 10,000 patients a year expected to benefit. So one is in high-risk locally advanced cervix cancer, the other renal cell carcinoma in patients at intermediate or high risk of recurrence following surgery as an adjuvant treatment, and locally advanced head and neck squamous cell carcinoma. And so again, we just can mention the papers that back this, the listing in high risk locally advanced cervix cancer was in Keynote A18 study. So it's giving pembro and chemo radiotherapy followed by pembro and showing a survival advantage in this group of patients. In Australia, this has become a pretty rare cancer, but this is now a standard approach in those patients. In clear cell renal cell carcinoma, high-risk patients, this listing is based on Keynote 564. So in that study, patients received typically for 1 year doses of pembrolizumab if they were deemed as high risk for recurrence following the nephrectomy. In the locally advanced head and neck squamous cell carcinoma listing, this is based on Keynote 689. Again, this is a perioperative approach, like we just heard about Durvalumab in muscle-invasive bladder cancer. Again, we talked about recurring themes, Rachael. This perioperative approach with doses pre and post-op seems to be perhaps a more effective approach than standard adjuvant treatment. So this Keynote 689 showed hazard ratios 0.73 with an event-free survival of 51 versus 30 months. Interestingly, there's no overall survival data. So this drug's been listed on the basis of event-free survival. Christopher Jackson would be horrified. But just to note that the parallel sort of study with nivolumab called Nivo post-op, which was giving just post-operative treatment, didn't show the same advantage and hasn't been listed as yet as a treatment strategy. So again, maybe suggesting that this perioperative approach is the way to go. So giving doses of immunotherapy when someone's immune system's still intact.
Yeah, so it's a clever approach, isn't it? It's very nuanced in that respect. And if we see this shift occurring, I think the comments by the health minister were quite incredible on this one. I don't know if you saw that. He said that this is one of the most extraordinary drugs available in the country. Quite incredible commentary, really, from the minister, highlighting that 10,000 people per year are expected to be affected.
There was previously 18 different listings. This is an additional 3, so 21 different listings. So you can understand why there's a push to maybe get a tumour agnostic listing for this drug as well.
And so, haematology. There's a few new things as well?
There is a few new things. So 3 drugs listed in haematology. The first one, this is where we're going to stumble on the names, elranatamab for patients with relapsed or refractory multiple myeloma who have received at least 3 prior lines of therapy. So, relapsed multiple myeloma used to have such a dismal prognosis. And the study behind this drug, which is a bispecific B cell maturation antitumor BCMA directed CD3 T cell engager, showed quite considerable activity in patients that had 3 previous lines of treatment with a response rate of about 60% and a median progression-free survival of 17 months. This is 4th line, people surviving 17 months on average, progression-free survival 17 months. That probably exceeded the 1 to 2 years prognosis of people when they were diagnosed some 10, 15 years ago. So it highlights the benefit we're seeing from these innovations and why it's so important that we need to make studies on these drugs available to as many patients as possible, including in regional Australia or in other priority populations, so that they can all benefit. So like all the bispecific drugs, the most important side effects include the cytokine release syndrome, and people who are using these drugs obviously will need to become adept at managing the side effects of these agents.
Interesting development. And the next unpronounceable drug, Gray?
It's Repotrectinib. Who'd have known? So this is a listing for patients at intermediate to or high-risk primary myelofibrosis, post-polycythemia vera myelofibrosis, or post-essential thrombocythemia myelofibrosis. So the haematologists or haematology nurses listening will know all about that, and probably the medical oncologist will be a bit perplexed. This is another oral kinase inhibitor. It works by inhibiting both JAK2 and FLT3, reducing spleen size and disease-related symptoms. Common side effects include diarrhea, nausea, vomiting, and anemia. So these need to be well managed because patients are on these drugs for considerable periods of time, and those even low-grade toxicities can have a significant impact on quality of life. But interestingly, one particular adverse event of note is Wernicke's encephalopathy, usually associated with thiamine deficiency, causing potentially fatal neurological toxicity. And of note, it's often seen in people with severe alcoholism. So it's suggested that thiamine levels are monitored.
And I believe there is one more, and this one I think is quite unpronounceable. See how you go.
Yeah, it's called mogamulizumab. How's that?
Well
mogamulizumab. And so this is for patients with relapsed or refractory cutaneous T-cell lymphoma. Again, I'm just going to have to be really careful how I say this, but this is a defucosylated, humanized immunoglobulin G1 kappa monoclonal antibody selectively binding to CC motive chemoreceptor 4. Oof.
Well
and there you are. So this is become another important treatment option in patients with relapsed or refractory cutaneous T-cell lymphomas. That's quite a niche drug. Expected about 100 people a year will benefit though. And isn't it great? All these people with rare cancers are now getting treatment options. And a big shout out to people from Rare Cancers Australia who have been really advocating very hard to get as many drugs possible listed in rare cancers.
Absolutely. It's a fantastic organisation.
It's really important. And then a couple of other little changes to note: big price cuts for drugs, some common drugs, abiraterone, anastrozole, bevacizumab, and azacitidine, as we see the impact of generics and biosimilars, and also an opening up of the listing for ruxolitinib and momelotinib. Now, some nurse practitioners are able to prescribe that under supervision. So big shout out to any of the nurse practitioners listening.
Yeah, fantastic. We know we have a good section of listeners that are nurse practitioners and readers. So absolutely big shout out. Do you think that this is something that's going to happen more and more?
Yes, I do. I think it's going to have to for us to cope with the workload of the cancer tsunamis upon us with an aging population and more treatment options, people staying under treatment longer. So certainly, we need to look at appropriate changes in new models of care, including training up nurse practitioners who are able to prescribe under supervision.
Yeah, absolutely. It's a really interesting point that we're getting to this apex of having so many new therapies and so much information and so much education that's required around the prescribing of all these second, third line therapies around specific molecular targets.
Well, it's been wonderful to chat again, Rachel, and share the information about these new innovations. We're delighted to hear feedback, and Rachel's will explain how you can do that on WhatsApp.
Yeah, absolutely. So in the show notes page, you'll see a little icon that you can press and it will open up WhatsApp and you can send us a voice note and we can include your lovely voice alongside ours in the next episode. So please do get in touch.
Fantastic. So we'll see you all next month, hopefully with some more exciting listings. And if you're not a listener of the OGC to date, also check that out.
Brilliant. Thanks so much, Craig. Looking forward to speaking to you soon.
Thanks, Rachel. Bye, everybody. Please don't take what we say at face value. Please do your own research, do your own due diligence, check the drug indication, be across the efficacy and toxicity data, discuss it with your patients before embarking on prescribing any of these bloody difficult to say drugs.
That's all for this episode of PBS Updates. For more information on the listings we discussed and for ongoing coverage of cancer medicines, visit oncologynetwork.com.au, where you'll find news, analysis and resources for oncology professionals. If you're working in industry and have details of compassionate access schemes or upcoming PBS changes you'd like us to share with the oncology community, feel free to get in touch. And don't forget to check out the Oncology Journal Club podcast if you'd like to hear more analysis and pearls of wisdom from Professor Craig Underhill. This podcast is proudly produced by the Oncology Network. Thanks for listening.